Hi, good afternoon. My name's Matt Dykes and I'm Senior Policy Officer for Public Services here at the TUC. I'm really glad to say I'm joined by Paul Evans from the NHS Support Federation, and what we want to do this afternoon is, in this webinar, is look at what's happening with the National Health Service. Headlines every day about the NHS in crisis, and we want to look at some of the reasons behind that and what's actually happening. So just introducing Paul, who's with me here today. Paul, do you want to say a bit about the NHS Support Federation?
Yes, no problem at all. I'm Paul Evans, Director of the NHS Support Federation, and we're a campaign group that has been around for around 26 years. The idea of the campaign is to really campaign and do research with the idea of protecting the principles of the NHS and to get both staff and the public involved in that process. And obviously, you know, the NHS is something that many people care about, but it's also something that comes under political attack. So some way of organising our information and our kind of response is where we're coming from, really. So we've been doing that for some time, and obviously at the moment there's a lot to be thinking about.
Yeah, and I advise you all to check out the NHS Support Federation website and the NHS funding website and NHS Not For Sale, all of which is put together by Paul and his team. Really high quality information that I suggest you look at. Now, what we're going to do in this webinar is we're going to spend about 20 minutes going through some of the key issues. We are going to go through quite a lot of information. We've got a few slides to show you, but hopefully it will roll fairly easily. Now, we'd like you to engage as well. We want this to be participatory. So underneath the video stream, you'll see an opportunity to ask questions. There's an Ask Questions button. So do fire in your questions, and at the end of our presentation, we'll turn to some of those questions and look at them in a bit more detail. But also, I think in the bottom right hand of the screen, there's an opportunity just to leave comments. So you can chat to each other, you can leave comments for us, and just keep it rolling. So I'm going to kick things off. Paul, as I said, the NHS is in the headlines. Our members who use the NHS, our members who work in the NHS, are seeing probably unprecedented stress and difficulties with the service. Yeah. And yet the government are telling us record levels of funding, more doctors and nurses than ever. Yeah. They're bringing in reforms to make the service more efficient and productive and integrated, and there's nothing to worry about privatisation, nothing to see here. It's just more of the same. So I want to investigate those sort of four key areas really to see what's actually happening. So should we start with funding? What are we seeing record levels of funding going into the NHS?
Well, the short answer to that is obviously no, and particularly at the moment we can see some of the results of underfunding very clearly. But it just in statistical terms, the one thing to probably take home about funding is that if you look at the amount that's been spent on average since 2010 to the present day, it's only 1% in real terms. Which is quite shocking really, because as you can imagine that's far less than is needed by the service to maintain standards, and yet throughout the period since 2010 we've had repeated assurances from the government and from ministers there's plenty of money going in, as you say, record levels, more each year, and when you look at how that distracts the public from some of the real facts about it, it's quite worrying because it gives us space for people to introduce the idea that the NHS is unsustainable. Mm-hmm. Perhaps there's something we're trying to chase, something that's not possible to do anymore. Time's moved on. Perhaps we're asking too much and we need to take more responsibility ourselves. These are all ideas that pop up and which challenge the idea of the health service at its very core, and I think it's important to get those key facts right before we let those ideas, start to infringe on the way that our health policy goes forward.
So just showing you on this, you can see on the chart in front of you, this is taken from the King's Fund and Nuffield Trust analysis of the Comprehensive Spending Review in 2015, and as you can see in the green bars there, we're seeing an average increase of around about 1.2% per year under the coalition government, and that actually falls under the current government from 2015. Just to put that into perspective, if we look at health service funding going back since the creation of the health service, what kind of levels are we seeing of average annual increases in NHS spending?
Well, I mean, the level that we've had since the NHS began averages out to be about 4%. And the interesting thing about that figure is really when you ask what the NHS needs, which is a good question to ask because we get lots of huge figures talked about. What does it actually need to keep up with the growth in population, demands from new technology, all those new treatments that we know keep coming online? Well, an organisation called the OBR, the Office of Budgetary Responsibility, has looked at that in a lot of detail. It's done the numbers and it comes up with 4%. So really what we have there is a parity between what we've got used to spending in average since the NHS began and what we need to spend. So really, perhaps there's a mind shift needed in political terms, that perhaps the steep hill that is given to us as being something we need to confront isn't so challenging after all, that the funding's perfectly possible.
And we see that, don't we? If we turn to this chart here, if you look at the blue line, that shows you average annual increases in NHS funding, going right back to the start of the NHS in 1948 there. And we can see that there's various levels of increase, and particularly sharp increases in the early to mid-2000s when the Blair administration took the decision to bring UK funding more in line with EU counterparts, and that's why we see that particularly steep acceleration in funding. But what we also see is a flattening out since 2010 under austerity, marginal increases, but certainly a flattening out, which certainly puts the government's claim that record levels of funding are going in, because that would suggest that by historical standards we're seeing great increases in spending, which we clearly aren't. The red line shows that, perhaps even more interestingly, health spending as a proportion of GDP, so how much money we have in the economy to allocate to the health service and how much we actually are. And that's actually falling since 2010, so that again puts that spending in perspective.
And that's an interesting figure because in some ways it's the easiest thing for a government to do, is to keep track of the economy. So as the economy grows, you spend the same proportion and the NHS gets more money because the tax take increases as your wealth increases. That's the theory from economists. But the fact that the government have chosen not to do even that, not to track the economy, is, I think indicates that they're deliberately following a policy of underfunding the health service, which we can talk about the reasons for. But in terms of where we're going now, in the next few years, it's not any better really, because we've just had a budget and there's a lot of noise there, perhaps reassuring us that more money is now going in. Well, in fact, the amount of money that the health service is going to get is 128 billion. When it really needs 153 by the end of this Parliament. So there's still going to be a gap of some 20 billions, a vast gap really. And now that we know what we need, the OBR have made that fairly clear, and many organisations are starting to adopt that particular figure as something to support. I think there has to be a real political call for these more realistic funding levels. To be organised.
No, I think you're right, Paul. And turning now to this chart where we're showing you, that blue line was the spending plans in place for the NHS prior to the autumn budget last year. You'll see this small red line here. That's the difference the autumn budget made. So this accounts for the additional 2.6 billion in revenue spending. There was a bit more set aside for capital spending, but in terms of the actual money given to the day-to-day running of the health service, that's the difference that the autumn budget made. So instead of seeing spending almost go down over the next 2 years, we're now seeing it marginally increase. But to make the point that you were just making there, this yellow line is what we would expect increases to be on the long-term historical trend, and that green line is what the OBR are saying the NHS needs. So even with these levels of funding that the government are giving, even after the budget has moved it up slightly, you can see an enormous gap there of around 20 billion by the end of this Parliament.
Yeah, absolutely. And I think it comes down to that straightforward 1%, 4%. It's been 1% since 2010. It needed to be 4%. And as long as you keep on that track, you're going to have a difference between what we're supplying and what we need, and that's obviously coming through every day in the news from NHS frontline. And
it's clearly a political choice, because when we look at, say, Europe, we're seeing other governments in Western Europe take a slightly different approach to health services, public health funding, aren't they?
Well, I think that's another reinforcement to the idea that the NHS is sustainable, because if we followed this OBR figure, we'd only reach the average that's been spent in Europe. So we'd start to knock on the door of France and Germany and the Netherlands, and be spending the sorts of amounts that they're currently spending. The interesting thing is that by the time we get there, they'll have spent more.
Yeah.
So, this is something to bear in mind, that the healthcare costs are rising all around the world. It's not a UK phenomenon. It's not because we're using the health service in the wrong way or doing anything that's particularly challenging that's not going, apart from cutting our expenditure, that is. But, it's a challenge for every part of certainly of every developed health system, and they're all spending more, and that's what we need to do.
And you can see from this chart here, the UK, out of below the EU 15 average, so that's the sort of 15 Western European early members of the EU, the kind of countries that we might compare ourselves more regularly to. And we can see ourselves languishing far behind the Netherlands, Germany, Sweden and France in terms of levels of actual health service spending, but also in terms of outcomes. So if we see the UK is the red bar there, so we're second from bottom in terms of number of beds per 1,000 people. We're bottom in terms of nursing staffing levels and bottom in terms of doctor staffing levels.
Yeah.
And that brings us on to the second of the key claims by the government, that there's more doctors and nurses than ever. More doctors and nurses since 2010. But our members are telling us they don't have enough staff to fill shifts.
Yeah.
They don't have enough staff to maintain safe patient-staff ratios. They're overstretched, and stress is increasing as a result, and patient safety is being put at risk, and standards of care are being put at risk. So who's right? Are the government right that we've got more staff than ever, or are our members right that there's not enough staff and there's staff shortages?
Well, I think, again, we can see some undeniable new bits of information that have come through which really give you a sort of sharp focus on what's really going on here. Recently there was a survey from the managers, from the people that are trying to run trusts across the country at the moment, and they said that understaffing posed the greatest threat to patient safety at this moment. And these aren't organisations that say these things lightly, and that's kind of chimes with something that a Lords Committee said recently in a report. They were looking at the sustainability of the NHS, and they were amazed to find that actually we don't have a long-term plan. It's been several years since we've had a strategic plan that's actually worked out how many staff we need and how to get there. So we can see that very evidently in the figures that are coming through about what we need. Now, of course, the government continually say that those numbers are going up. So when they say that NHS England says that the number of clinicians has gone up by 40,000 since 2012, well, that could well be right. But what it doesn't take into account is the fact what we need is another 40,000 nurses, midwifery staff, nursing in the community. There are real differences between what's been planned and what we actually need, and that's the sort of change that's necessary for us to start to get a real grip. And obviously it doesn't happen overnight. These are things that have to happen over time. So I think proper planning, but also there's a need to get across the fact that the government have been doing more than just not planning. They've actually been physically cutting in certain areas, or they've been putting into conditions that there will be cuts. So obviously, areas like district nursing, there's been a 26% decrease in the numbers of district nursing, which is an amazing fact given that the government are so keen on doing more healthcare in the community. So this whole idea that we're planning a proper future that's properly funded and strategically sound, is full of some fairly large holes.
And we're seeing cuts in sort of mental health nursing, community nursing, so all the areas where the government are saying are part of priorities in the 5-year NHS plan are areas that are being cut. Now this picture here shows you sort of some broad staffing trends. What you see at the bottom there is managers. So there was a fall off there when they abolished, in the 2012 reforms, they abolished primary care trusts as a strategic health authorities, and we saw a decrease in the number of managers, although what they're seeing now is that number go back up when they realise that they do need people who have strategic management over the health service, that they weren't all bureaucrats and pen pushers, and they actually provided real added value. So we're seeing that figure go back up now. We're seeing consultant figures steadily rise, but the rest are all sort of marginal increases, and actually this pale blue line shows you that nursing and midwifery has actually flatlined, and really worryingly we're beginning to see it decline in real terms for the first time in about 3 years. Now, making the point that you made there, Paul, about it's a long-term problem, because the single biggest factor on nursing and other staff numbers is training. And of course that's where big cuts are being made too. So we saw in 2010, when the government came in, big cuts that led to this large decrease in the early years, those blue lines you can see at the beginning. Then they rectified that, the new training supply came through, and we saw an increase in numbers, but again we're seeing that fall off. Why are we seeing staff shortages? Well, this is a survey undertaken of NHS employers. This is a survey of NHS employers by the King's Fund, and their single biggest issue there is blockages in training supplies. So we're seeing a fall off in training. And interestingly, we saw a 23% fall in people applying for training places after the abolition of training bursaries.
Absolutely.
So everything that every health union predicted is now transpiring. The second biggest issue was morale and overwork, and of course that's a vicious circle, because the fewer staff you have coming through, the more overwork, the more the morale declines, and the more people leave the service. And the third one was pay restraints. So we're seeing a sort of toxic combination of lack of training places, overworked, demotivated staff, which has led to, for the first time in about 3 years now, more people leaving than entering the profession, and pay restraint exacerbating that, and nurses earning around £3,000 to £4,000 less in real terms than they were back in 2010. And the final piece, I think, is Brexit. Astonishing figures there. 10,000 EU nurses alone have left the NHS since the EU referendum, and we've also seen a 93% decrease in new EU nurses coming over since the referendum. So it's a sort of more people leaving, fewer people coming in. So we've lost that supply of EU nurses who are plugging a lot of those gaps.
Absolutely. And the government had a target to raise to bring over 2,000 GPs. And they've managed to get over 38 according to the latest figures. So, people are just taking the message that actually we're not quite as open and receptive to people coming over from the EU as we were, and even if it's just about doubt, then that's stopping people, and we do rely on that infusion of staff from other places to keep the health service going.
But of course, the long-term solution, of course, is investing in training and having a proper workforce strategy, like you said, and we're cutting back on the training, and we don't yet have a really comprehensive workforce strategy.
No, and the number of vacancies shows exactly that that's the case. We're not paying enough. We're not paying staff enough. We're not organising places for them to live and so that they can get to work. And I think that in areas like paramedics, one in three of the posts are unfilled at the moment. So that's going to have a huge impact in terms of our ability to respond to the current demands.
Sure. Okay, so we've looked at the situation with funding, we looked at the situation with staffing. The government are also saying that there's more long-term problems though. We have a disjointed and fragmented health service, the different parts, so primary care, GPs, working with secondary care and hospitals and acute providers, mental health. That's not joined up, and nor is it very well integrated with social care, particularly with older patients, and getting them into proper residential care or home care after leaving hospital is really problematic. We all know this is a problem, and the government's saying they're bringing in reforms to make this all work better, mainly through the NHS 5-year plan, which includes the breaking up the country into 44 sustainability and transformation plans. Now these have come with a fair bit of controversy attached to them. Personally, I get what they're sort of trying to do in theory, but what's actually happening in practice? What are the risks inherent in this, do you think?
I mean, first of all, they've not made it easy for us, have they? Sustainability and transformation plans, pretty tricky terminology it doesn't exactly grab you. And I think, considering what they are, the aim is to produce a 5-year plan in every area, which kind of says, well, what are the health needs of the population? How can we reshape things so that we get a good, solid plan, and how can we move that forward? Well, that's the idea. But actually, when you look at the plans, they're very, there's a lot in there which is you would agree with in terms of trying to produce healthcare which is more appropriate for the population, trying to improve health outcomes, having more health prevention. All of that stuff is at the front of these plans. But what we don't see is a real worked out, funded, step-by-step guide about how they're going to get there. And the reason for that is that they have conflicting aims. So on the one hand, we have these bold, strategic, kind of blue sky aims in the SDPs, but actually behind that there's some co-aims which the government have put in, which are about returning each area, and you have to bear in mind that every area, every SDP area has a deficit. They have to return the area back into surplus before they can move forward with the plan. So that has to all be part. It's like a business plan, essentially, to create a new way of bringing the whole area back into surplus.
So by way of example, in my neck of the woods, the North Central London Sustainability and Transformation Plan has a forecast of around about an £800 million deficit just in that area between its different component parts of the NHS by 2020, and as well as finding a way to integrate the health service and social care in that part of North London, at the same time it has to find 800 million in savings.
Yeah, and when you give it that kind of challenge, you know, blue sky thinking and strategy goes out the window, because really it becomes about how do we find a way to save money, essentially. And so when you look at the hard proposals, then really are talking about acute reviews. So are our hospitals able to provide what we need? Are there ways in which we can reduce bed numbers? So many of the SDPs have targets to reduce acute bed numbers. There are about around 20 A&Es that are proposed for closure. Community hospitals are being closed already, and this is common throughout. So it's the first stage of the plan, really, is how do we achieve a reduction in spending in the more what's seen as the more expensive side of things, the acute sector, and prepare for what they're saying is a greater investment in community health. But what's not there is where that money's coming from. And the BMA went through the plans and totaled the cost to be around 10 billion, the need for investment to achieve some of this growth in the community sector. But it's just not there. So there is a big fat hole where you need to invest, and there's also a stress on cutting back in the acute sector before doing the investment in community services.
So you cut hospital bed numbers, but you don't have anything to make up for it in community provision, which just is generally a cut, isn't it?
Exactly. And so that's why the public are becoming cynical. You're starting to see people respond to some of these individual ideas to merge hospitals and actually increase the amount of distance it takes to get to get the care you need. And people are really starting to get concerned. The good thing about that is that they are getting concerned and they're getting engaged with something which is, up until now has been completely impenetrable, difficult to grab hold of. But it's really important because of the fact that this is the basis, this is the vehicle through which the government are trying to bring in some of their new ideas. Other, more acronyms, MCPs, PACs, ACOs, there's a whole pile of them. But what that really means is an attempt to integrate health and social care, but also maybe leave some of the market influences in there that have been present in some of the other ideas in the Lansley reforms. Yeah,
so there's a school of thought out there that says that this is really just a way of breaking up and parcelling up the NHS to make it attractive for private takeover. We haven't yet seen enormous privatisation of services at that kind of scale. Have we, Paul? Are the government right that privatisation isn't the threat that some people are making it out to be, or should we actually be concerned?
Well, I mean, certainly with SDPs, as far as SDPs are concerned, then you could look upon this as a new opportunity for the private sector. And certainly we see some evidence that their ability to win contracts in community health, for instance, means that they're well placed to then adapt to the new emphasis in community health. So look at Virgin, for instance. They've just won £1 billion worth of contracts in the last year to run NHS services, and typically they focus on those community health services. They're complicated contracts, and in Bath there's one particular contract which is groundbreaking because it combines healthcare and social care under the same umbrella, and this is exactly where you could see it go in the future once these new models of care come into being. A lot of healthcare under one big umbrella, perhaps provided by one organisation, and the concern is that the government haven't yet ruled out the possibility of that being a private provider, and until they do that, we can't be rest assured that we're going to have a public driven health service in 20-30 years time. Now there has been a bit of attempted reassurance from Simon Stevens, who is the Chief Executive of NHS England, that we've come to the end of the Lansley era, which was, you know, the attempt to introduce competition to get the NHS and private providers to compete for contracts. And he's saying that actually that isn't working. And we've done some work tracking that whole process, and obviously it's been a huge distraction for the NHS to essentially compete for its own job, and in some instances it does actually lose. In many instances it's been losing over the last few years.
Well, we've seen that with in your latest privatisation report. I mean, do you want to talk us through this figure, Paul?
Yeah, I mean, obviously the Lansley reforms were really brought in 2013. So over that time, we immediately saw, in fact, as soon as they came in, a big step up in the amount of contracts going into the market, for want of a better description. So basically, NHS and outside providers and charities could compete to provide those contracts in a tendering process. So we looked at who was winning them, and it was obvious across time that the NHS wasn't doing very well in this process and losing out time and time again to either the third sector, but principally to private providers who, let's face it, tendering is their game. You know, they've got the staff to do it. They're more organised, so it's not really surprising that that process is taking place or has been taking place. And the important point to bear in mind is that the rules that mean that trusts have to advertise these NHS contracts are all still in place.
Yeah, exactly.
It was brought in by Lansley.
Section 75 regulations.
Exactly.
Yeah.
Brought in by Lansley. It's all still there, and it's like a sausage machine, basically. Those contracts still go out into the market, and out come a certain proportion which will end up going to private providers.
And what you're saying is that that's largely taking place in those areas like community provision, where if we follow the logic of the 5-year plan, the NHS is going to focusing more and more of its resources. So while we're not seeing large-scale private takeover of hospitals, what we are seeing is private companies like Virgin and Care UK positioning themselves in the part of the market that is set to expand.
First of all, that mechanism is still in place. So the government, they haven't removed the competition regulations. So all that waste, even though they've recognised it's not the way forward, that still has to occur. They can't remove it because of their political difficulties in Parliament. They're too weak to come up with some new legislation. So we're getting a kind of lean-to arrangement for the time being. And that's something we can challenge on, because we shouldn't be resting with a system that doesn't work for patients and doesn't organise care properly. If the government are recognising it, they should do something about it. But the problem with the community, the reliance on the private sector, is that we're passing control. We're passing control gradually of our healthcare system, the supply of beds, of services to private providers who don't necessarily share the same objectives. And we can see in long-term care where there's real problems providing care for older people now, because it's all gone out to private providers. We don't control that supply of care anymore. So that could happen too within community health, and we just got to be very mindful of the downside.
Sure. So Okay, we've covered a vast amount of ground there in as short a time as we were able to manage, slightly longer than we had anticipated, perhaps. We know the sort of problems we're in. I'm going to put you on the spot now, Paul. 3 things that you think a government should do if we want to see a publicly accountable, publicly owned, fully funded health service, the kind of health service that we believe in, that we love and that we want to see.
Okay. Well, first of all, we've talked a lot about funding, so we've got to get that right. And also, it's not just about the NHS, because when you increase funding to the NHS, we're not dealing with the other half of the equation. Social care funding has been cut, and aggressively so, and that is. There's a kind of relationship now between the two sectors, which going forward we've got to recognise, and it makes no sense to have people stuck in hospital because there's not the community services outside, and it makes no sense to neglect their care, so they end up in hospital. So we've got to fund both sectors.
So funding?
So fund both sectors, 10-year plan at least. And commit to something which is based on need. We've got the figures, we know what we need, so try and base our funding predictions, funding commitments around those.
Okay.
We're moving forward to a new, we're trying to transform the health service. That's the government's aim. But let's be honest and open about what it's about. I think the government needs to give us a vision of where they're headed. These accusations of the NHS being privatised are there for good reason, because there is some evidence, and they haven't strongly given us an indication that they want a public health service. So we need that. So we need them to take out these competition regulations, to look at reforming the whole system so that we're committing to public service going forward.
And finally?
Well, it's a public service. It's run for the public, but it's run by NHS staff, and at the moment a lot of these changes just don't include their views. Millions of staff don't really understand the process that's going on with the SDPs because they haven't been asked, and that's let alone the public. So these are big changes, and people have just been cut out of the process.
And underpinning all of this is time. Give the NH time to plan, invest and change properly. Stop the rush.
Stop the rush.
Great, thanks Paul. I hope people were able to take something from that. We can make any of this information available. If you want to email us back at a later date, we're always happy to share information. And as I say, check out Paul's the NHS Support Federation website. But we do have some questions, don't we, Holly?
Yeah, we've got a few questions
from
the audience. The first one is from Zoe Fox, and she says, I understand Cornwall Council is considering an ACS. This is being confused with an American-style ACO. Are all the options a disaster? I understand some actually allow previously fragmented services to be brought back together in-house.
Well, Paul, this is the point we were sort of making earlier, isn't it? That on paper, an STP, or actually an accountable care system, what they're flagging up in Cornwall and other parts of the country, which is a slightly more integrated version of a sustainability and transformation plan, isn't it? Is bringing the local authority, social care providers, NHS providers and commissioners all together under one roof to plan effectively. That's a good thing, isn't it?
Of course. And I think if you start with a blank sheet of paper, in Scotland they combine health and social care. In Northern Ireland too, it's got to be the way forward. So getting people around the table, commissioning jointly or organising care, planning care. Let's get to that level where we're planning care together. But who controls those organisations? How are they governed? And what's the rules behind what they're trying to do? So the difference with an accountable care organisation is that there's a contract. So you're asking one organisation, and I think this is something where the government needs to clear up. They need to tell us, what they're planning, because one could be quite a good idea, an alliance between organisations run for the sake of the public, something. But we've got concerns because obviously if you restrict the budget and say, well, this is capped, it can go no further, then what happens if you get a flu epidemic, or if you don't plan your health, your staffing as well as you could? There's got to be some room for that, and these models are about constricting how much we spend. and passing control perhaps to the private sector. So we need to watch out for
exactly. And if you go into a fully fledged accountable care organisation under a contract, that contract could be won by an independent or private sector provider.
Exactly.
Even if it's won by a public provider, an NHS body, it's still adding layers of fragmentation in the system, isn't it? And that's what our concern is. So bringing providers together in an area, planning and integrating is a good thing, but there are real concerns there about how it's handled and the potential for marketising that service.
Yeah, absolutely.
Yeah. Okay.
So the next question is from Richard, and he says, why is there a crisis in the NHS when the funding from government should be sufficient to have all hospitals fully equipped with the beds required and staffing? Because the contributions from the national insurance taken from every working person hasn't gone down.
Well, I mean, it's an unfortunate fact that the funding just isn't there, and I think we covered that early on. And the problem with that is
the funding's going up,
the
but
funding's
just
going
not
up
at the levels required.
but not at the levels required, and that's where the politicians have been a little bit unhelpful, to say the least. Because we talk in big numbers and always about record levels, and actually what we need to do is think about, you know, what we need versus what we're spending, and get more of a grip on that, because then you can see that actually, beds have to increase, you know, staffing has to increase. We need to have the capacity for the health service to treat the amount of illness that we have.
Yeah, and of course population is increasing, particularly age groups over 65. Over 85s have really ballooned, and that's a great thing. You know, I mean, that's a testament to the benefits of public health, that we're living longer. But that means that we're living longer many times with comorbidities, complex long-term conditions that need to be managed. So the demand on the health service is outstripping supply, if you like. And
but there is obviously an obvious point there. The population doesn't expand overnight. You know, it's not like old people are waiting around corners for us. We can see them coming. People have time to plan, and we've known about the fact that cost pressures are going to rise, and we haven't put the money in. So you know, we're now in a situation where we've got a deficit. It's going to take time to sort it out, but we've got to do it quick.
And the really important point you made at the very beginning of this presentation, Paul, is that the cost pressures identified by the Independent Office of Budget Responsibility in order to meet that increasing demand is just a 4% increase per year, and that is historically what we always got. So that is sustainable. We're not asking for a massive escalation in NHS funding.
Yep.
If we brought average increases for the health service budget back in line with what we traditionally have done since 1948, we would be somewhere closer to what we actually need.
Yeah.
But the point as well in terms of is this enough for our hospitals, looking at this slide, this is the impact on NHS providers over the last few years. Now, what this shows is that in 2012-13, just 11% of NHS trusts finished the year in deficit. By 2015-16, that had escalated to 65% of NHS trusts around the country could not balance their books because of this squeeze on their funding, and that's a total from going from 577 million surplus in 2013 to a 2.5 billion deficit at the end of 2015-16. And this isn't because of inefficiency and waste, because if anything, over this particular time period, NHS productivity has increased. The NHS has found better ways of working. Yes, technology and other things have become more expensive, drugs have become more expensive, but the actual system itself is running at very little slack in the system, as anyone working in the service will tell you.
I mean, productivity in the NHS has outstripped the economy.
Yeah.
So, you know, 1.7%, which outstrips how much we're improving in productivity elsewhere.
Exactly. And that's the impact on Paul. That's the impact on the NHS providers, the trusts. This is the impact on those commissioning the service, the clinical commissioning groups who plan how much money goes to which provider. And they were surveyed by the King's Fund, and they said, in order to balance your books in 2017-18, what steps are you going to need to take? And a majority of them said we're going to have to increase waiting times and cut back on certain treatments. So the first big block there is they're going to increase waiting times. The second is to cut back on what they consider low value treatments. Really worryingly, they're going to increase, many are thinking about increasing criteria for treatment. So that's having perhaps restrictions on services provided to smokers or people who have obesity or other conditions. Basically what we're talking about is either longer waiting times or rationing of services, and these are the people who are actually planning our health spend. So clearly there is not enough money for those commissioning the service or those providing the service.
And the big danger here is really what we're seeing is, the health service always has rationing, so we've always had to wait. In fact, we've waited quite a long time in the past until Labour came in and started injecting huge sums. We started seeing some real improvement in waiting times, and we're going back to that period where people are being forced to wait longer. We're not introducing treatment because we can't afford to do it, or there's been closure of units, maternity units sometimes shut down because there aren't the staff there that's doing to service the service. So it's a real problem in just doing the basics that need to be done.
Yeah. And make no mistake, this is having an impact on the service. I mean, here's we're going to race through these, but look, this is the A&E waiting times going up, waiting lists going up. The number of people waiting longer than the target for cancer treatment going up, and the number of people staying too long in hospital because there's insufficient provision for them out in the community also going up. So we're seeing, despite the best efforts of NHS staff who are under massive pressure and NHS commissioners, we're seeing performance deteriorating along a wide range of key performance indicators.
And there's one danger really of those changes that you mentioned, of rationing, because really what we're talking about is the idea perhaps of introducing more personal responsibility for healthcare. We're seeing more people having to dip into their own pockets to get treatment, and that's okay if you can afford it. Well, it's not okay actually, because we need to continue sharing the cost of the health service between us all, and there's some real issues that we need to get to grip with, because if we allow the current drift through underfunding, then we're going to be paying for physiotherapy, for long-term care. We already pay for dentistry, but podiatry, to go and get your eyes fixed. More of these discrete services, diagnostics, will be routinely paid for, and that will be the expectation, and that's the beginning.
That's the thin edge.
That's the beginning.
The thin edge, isn't it?
Exactly.
Okay, Holly, have we got any more coming through?
Perhaps we've got time for one more question.
One more, okay.
So this is from Leslie, and she says, as we hear in the news, healthcare professionals, it's not just nurses, they're leaving the NHS and their experience is going with them. Will we be seeing a new skills crisis in the future?
Well, the first thing I want to say in answer to that is I want to apologise to all our friends and members out there in the health service when we talk about doctors and nurses.
Yeah.
We use that because it's obviously an obvious frame of reference, and it's one where there's particularly strong numbers, and we use that as an indicator. But no, you're right. The same issue is facing radiographers, it's facing physio and occupational therapists, it's facing support staff across the board. Are we seeing a skills crisis, Paul? My guess is, we will, unless we get a decent workforce strategy in place.
It's impossible to recruit staff unless you pay them properly and retain them. They don't appear overnight. It takes a structure, a process. You've got to invest in that and attract people. Who wants to come and work in the health service in the current situation? We're very lucky to have a dedicated staff cohort that we have, over 1.4 billion staff, 1.4 million staff, and that's a huge number, but I don't think we can rely on them doing the extra hours that they do. We've got to start taking account of what we really need to spend and increasing what we're willing to pay to get the staff that we need.
Yeah. And of course, what we're also seeing in some places is downbanding. That's where people are being asked to perform tasks in order to plug gaps for things they're not necessarily qualified to do, or at least not necessarily graded and paid enough to do. So we're seeing additional responsibilities put on the shoulders of people because we're not pulling through enough people with the right skills. So that's a real problem as well.
Yeah, absolutely.
Brilliant. And we can answer any more questions later on.
Okay, sure. Okay, so I think we're going to finish up now, and if there are any questions that are unanswered, we will get back to you. We've got their email addresses, have we, Holly? And we're very happy to come back to you. But I want to raise one last thing for all of your attention, is that a day of protest has been called on Saturday the 3rd of February. So if you do want to join our partners in Health Campaigns Together and the People's Assembly, and those unions representing health service and social care staff, then please add your voice. Come and join in the protest. There's a march in London on Saturday the 3rd of February, but there are also events taking place around the country, and all those details will be available. If you go to, say, the Health Campaigns Together website, you will find more of that. So please do come and join us and make your voice heard.
Brilliant.